Hello there. Here we have our second of the 3 kidney lectures. We started off with learning the parts of the kidney, learning the flow through the kidney from the renal arteries to the interlobar arteries, the arcuate arteries, out to the arterioles moving into the glomerular capillary ball. So we have the afferent arteriole coming in. The blood goes through the glomerular capillaries inside a Bowman's capsule, filters about 20% of its fluid. Then it leaves via the efferent arteriole. Then it goes down to the peritubular capillaries, meaning around the tubules. And it then reabsorbs a lot of the stuff that you filtered out to begin with. You wind up reabsorbing most of what you filtered out. You secrete some more stuff that you want to get rid of extra. So you have filtration at the glomerulus, you have secretion at the tubules, and then you have reabsorption at the tubules. So you're constantly putting stuff back and forth from the blood into the urine or back into the blood so that you keep exactly what you want in the blood and you pee out the rest. Excretion is the removal from the body. So what goes out ultimately goes out in the urine is excreted from the body. Okay, so here we go. Let's see if we can make this work. Oh, here we go. Okay, so today we're going to talk about reabsorption, what you take back and where it happens, and therefore how you wind up with your final urine concentration and contents. Most of the tubular contents get reabsorbed. We know that we filter out about 125 mLs per minute. That's a lot. So your initial urine, your initial filtrate, is a pretty large amount. You reabsorb most of that and you only pee out a small fraction of that. You definitely reabsorb all of the nutrients. So you're not supposed to pee out glucose or proteins. Fats, you don't pee out that stuff unless you have kidney disease. You adjust water and ion and vitamins and stuff reabsorption depending on how much you need to keep in your blood and how much you want to get rid of, just so you don't overdose on stuff. It includes a variety of active and passive reabsorption processes and 2 overall types. Transcellular means it actually goes in one side of the cell and out the other, so it's crossing the cell itself. It's got to have importers and exporters on the cell membrane. Paracellular means between the cells. So these cells have tight junctions, but they're not all that tight. So some things are able to move between the cells to get from the tubule back into the blood or vice versa. Paracellular route, again, not super tight junctions. Water moves this way. Now, kidneys are a little bit different than other tissues where water in your leg, it moves just by osmosis. Just because solute moves, water gets pulled by osmosis. In the kidneys, the tubules, a lot of the tubules aren't permeable to water. They're more like a garden hose that has a bunch of little holes in it that can be opened or closed. So you actually have the ability to control water movement in the kidney tubules in a way you don't anywhere else in the body. But water, to some degree, can squeeze between cells. So can some of the ions. And water is moved by osmotic pressure, but it only moves if you open up those holes to let it go. So you actually have some control over water movement. That way you can pee more or pee less, depending on what your blood needs. The transcellular route means the real thing, where your cells have importers and exporters so that you're moving stuff from the tubule inside the cell, then outside the cell and back into the blood. Use every kind of transporter that we learned in A&P 1. You have simple diffusion, you have facilitated diffusion, primary and secondary active transporters using usually sodium to drive the secondary active transporter to get some other things across. Some hydrogen secondary transporters are found on the kidney tubules. So here we have look at the kidney tubule. Here's the P. Here's your blood. You're trying to get the things that you want to reabsorb back into the blood. Everything else will be excreted and peed out. So, water and solutes come in the transcellular route through various pores and things, and they get moved through a variety of transporters. Some of it will find its way into the area between the cells. Other of smaller amounts will go the paracellular route in between the cells. Again, transcellular, you have to go through two membranes to work your way over here. Paracellular, you just need to squeeze between those tight junctions to get over there. Sodium is the most abundant ion in extracellular fluid of all kind. So just like everywhere else, if you move sodium, you can run secondary transporters. So just like in the intestine, we have a bunch of sodium, potassium, ATPase pumps on the basolateral membrane, not the membrane that faces the P, but the membrane that faces your tissue. And it's constantly pumping sodium out of the cell and into the tissue, using ATP energy to do it. Driving sodium this way causes sodium to get sucked in this side, and there's a ton of it, and so you use it to run a lot of secondary active transporters over here to suck in glucose, amino acids, and various and sundry other things that you want to bring in. So if you keep the sodium-potassium pumps running on the basolateral membrane 24/7, you can keep this concentration gradient of sodium moving this way and use the power of sodium to pump in solute from the other side using secondary active transporters. Secondary active transport. Sodium reabsorption by primary active transport provides the power to absorb most other things by secondary active transporters. Chloride will follow through facilitated diffusers and also some paracellular between cells. Remember, if you move sodium, chloride is so attracted to sodium. Sodium chloride is salt. Sodium follows any way it can, and so it winds up getting sucked through too. So you wind up taking a lot of salt from the urine and putting it back into your bloodstream. Not too much, because you don't want to OD on it, but a pretty significant amount of sodium and chloride wind up being reabsorbed. Now water, if there are holes to let it move, will be pulled by osmosis because sodium and chloride have osmotic power and will pull the water. Organic nutrients like glucose and amino acids are absorbed by those secondary active transporters. Some ions also. And then water gets absorbed by osmosis. So we're mostly, remember, we filter all this, a lot of stuff in there. We want to reabsorb most of it. And so we are, we absorb the sodium and other solutes and glucose and everything back into the blood, and water gets sucked back by osmosis, by osmotic pressure. And so you wind up absorbing most of what you filtered out, your solutes that you need, and then the water follows them. Water is absorbed by osmosis. Now those little channels that you can open and close in the kidney to make more or less water move are called aquaporins. They have a beautiful name, aquapores. So you open them in response to something like anti-diuretic hormone. It opens these guys up and prevents you from peeing out too much. Diuresis is losing water. Anti-diuresis means you're reabsorbing water. So ADH will open a lot of aquaporins along various points of the tubule and allow water more easily to be reabsorbed back into the tissues. Aquaporins are inserted into the tubules, the collecting ducts primarily, only if antidiuretic hormone is around. So antidiuretic hormone is your primary controller of pure water, moving just pure water back. Water-soluble substances don't cross easily. We know that from previous stuff. Water-soluble substances can't cross a cell membrane, so we can control them pretty well. We pump more of them across, or we pump less of them across. We want to reabsorb the amount that we want, and we want to pee out the rest. Fat-soluble substances we don't control well. They cross the membranes easily because the membranes have a fat center, and so fat crosses fat. And so most of your fat-soluble substances get reabsorbed passively just because they can cross so easily back into the bloodstream. So lipid-soluble drugs, environmental pollutants that are lipid-based, will wind up being reabsorbed back into the bloodstream, and it's hard to get rid of them. Now, that's good if it's something you want to keep, but it's not good if it's not. If you smoke pot and you wait a week and go have a drug test, you'll still have pot in your bloodstream because THC is lipid soluble, and as it goes through the kidney, it just gets reabsorbed back into the blood. You don't pee it out very fast. So here we have a good look at it all. Here we have the sodium-potassium pump is busily pumping sodium out so that it goes back into the blood. So we're reabsorbing sodium that way. Chloride is following the best it can because it likes sodium so much. We're pumping potassium the opposite way because remember, sodium-potassium pumps sodium one way and potassium the other. Much of your potassium finds its way through a facilitated diffuser, but a lot of the rest of the potassium gets peed out. So you actually wind up intentionally getting rid of excess potassium. Generally speaking, we eat more potassium than we need. Now, if you get low on potassium, you got to eat more. You got to eat bananas or something like that. But generally speaking, you're intentionally getting rid of some excess potassium. Now, if you have an overactive sodium-potassium pump system here, we mentioned this before, you will have reabsorbed too much sodium, and your blood pressure will go up, but you'll also lose too much potassium, and therefore you have hypokalemia. So anyway, we're pumping sodium across. That helps pull the high concentrations of sodium in here to run the secondary transporters that are bringing in glucose, amino acids, and some other stuff. Lipid-soluble substances are just going across because they can. Some other things fit through the tight junction without being slowed down too much. And ultimately, you're getting all of this stuff back that you want. Water then gets pulled through by osmosis because all of this solute produces osmotic pressure that sucks water across, and you wind up reabsorbing your water and your solutes this way. Meanwhile, as we mentioned before, you're constantly running a few pumps in the opposite direction to secrete some of the things that you want to get rid of even more, like creatinine, the muscle breakdown product that you're trying to get rid of. You actually have creatinine pumps that move it this way, so you'll pee out more of it. Mostly, you're reabsorbing stuff. Some secretion, though, is taking place for substances that you want to get rid of. And remember, anything that you use transporters to transport back into the blood, the transporters can be overwhelmed. If you have too much of that substance in your blood and therefore in your primary urine, you'll absorb it as fast as you can, but you can't absorb all of it and you'll wind up peeing out some of it. Again, hyperglycemia, high blood glucose with diabetes. You exceed the transport maximum and you start peeing out glucose, which you're not supposed to. So, where do your various things get absorbed in these kidney tubules? Remember, I said the different parts of the tubule have different things that they do. Well, the first thing to remember is that the proximal tubule reabsorbs most of everything. 65% of everything gets reabsorbed right away. Okay, you know you're going to want to keep most of your water. You know you're going to want to keep all of your glucose and amino acids. There are a lot of things that you want to keep, and you know that right off the bat, and so you absorb it right away. So 65% of everything gets absorbed in that proximal tubule before you even get to the loops of Henle. Then, the descending loop absorbs water. It's permeable to water, so the water can leave and go back into the blood. Then the ascending limb is not permeable to water, but it's permeable to electrolytes, some other solutes, but mainly electrolytes. So you absorb most of your stuff in the proximal tubule, then you absorb a bunch of water, and then you absorb a bunch of electrolytes. And then you fine-tune it out here, and we'll talk about that in a minute. Reabsorb a lot of water early, and the descending limb here, and then the ascending limb is electrolytes. Then the collecting duct, the distal convoluted tubule, the distal tubule, and the collecting duct, you have a bunch of cells that are regulated by hormones. Antidiuretic hormone, aldosterone, atrial natriuretic peptide, and parathyroid hormone. These four primary hormones turn these cells on and off so you reabsorb more water, more sodium, less sodium, more calcium. So the collecting duct in particular has tons of these cells that are stimulated by these various hormones to fine-tune everything. You reabsorb most of everything in the proximal tubule, water in the descending limb, electrolytes in the ascending limb, and then you start fine-tuning based on your hormonal amounts. So, these cells in the distal tubule and primarily the collecting ducts are called principal cells. Principal cells. They have tons of aquaporins and other, sodium potassium pumps and things like that that can be stimulated by antidiuretic hormone and aldosterone and parathyroid hormone and the like. Antidiuretic hormone in particular causes aquaporins to be activated. They actually move to the membrane, open up, and let water through. Remember, antidiuretic means less pee. If you don't have this, you pee too much. If you have enough of it, you control the amount of pee so that you can retain water. Antidiuretic hormone retains water by opening aquaporins so the water can be pulled back into the blood more easily. As ADH levels increase, you reabsorb more water back into your blood. Too much ADH, and you retain too much water and your blood pressure goes up. Too little ADH, and you pee out pure water, very dilute urine, lots of it. Your blood pressure goes down, diabetes insipidus. Aldosterone, we remember from the renin-angiotensin-aldosterone system. Aldosterone is made in the adrenal cortex. it moves into the kidney tissue, and it targets those principal cells and in the collecting ducts and distal tubule, primary collecting ducts, and it turns on sodium-potassium pumps, and therefore it pumps more sodium back. It increases sodium reabsorption. Now that also pulls water by osmosis. So the actual action of these is to increase sodium-potassium pumps to increase sodium reabsorption into the blood, which secondarily pulls a lot of water and your blood pressure goes up. So remember, renin-angiotensin-aldosterone system is designed to raise your blood pressure too. But it doesn't just bring in pure water like ADH does. It brings in sodium, and then water gets pulled by osmosis. And too much of it, you retain too much sodium and lose potassium. Excess aldosterone will cause hypokalemia because you're pumping all that potassium in the opposite direction. We remember ANP vaguely from the cardiac section, atrial natriuretic peptide. Remember, diuresis means getting rid of water. Natriuresis means getting rid of sodium. ANP causes you to pee out more sodium, and the water follows in that direction. So ANP is designed to lower your blood pressure. It opposes aldosterone. But remember, it's not as powerful by far as aldosterone. So if you have too much aldosterone, ANP simply won't do the job. But it's a good fine tuner in healthy people. And parathyroid hormone will act on those distal tubule cells in particular and increase the reabsorption of calcium. Remember, parathyroid hormone increases plasma calcium. You take it out of the bones, you absorb more at the gut, and you also reabsorb more in the kidneys. It does everything it can to raise calcium. Now, secretion of extra stuff primarily happens in the proximal tubule. So where you're trying to reabsorb 65% of everything that you know you want to keep, you're also trying to secrete everything you know you don't want to keep. So a lot of this stuff happens real early. You reabsorb a lot of stuff without fine-tuning it at all, and you secrete stuff that you know you want to get rid of pretty early. A lot of potassium goes out. Hydrogen, if you're trying to get rid of acids, hydrogen is acid. Remember, hydrogen ions are acid. So you can secrete acid and therefore excrete it. If you excrete acid, it means it's leaving the body. You get rid of ammonia from the digestion of proteins, and you get rid of creatinine, which is a byproduct of muscle action. So these things you don't want to get rid of all potassium, but you want to get rid of a lot of stuff pretty early, especially ammonia and creatinine. You're trying to really clear those out completely. Bicarbonate is your base. Remember, we make bicarbonate all the time to neutralize stomach acid. It comes out of the ductal cells and stuff. We're always making bicarbonate. We make bicarbonate to carry our CO2 back to the lungs. Bicarbonate is base. Hydrogen is acid. Bicarbonate is base. We'll have our acid-base balance lecture next. That will be our next lecture. But your kidneys have the ability to either retain or excrete hydrogen, get rid of hydrogen, pee it out. You also can retain or excrete, pee out bicarbonate. So if you get rid of hydrogen, you make your blood more alkaline. If you get rid of bicarbonate, you make your blood more acid. And here I'm saying it again. You control your pH, your acid base, by altering the amounts of hydrogen or bicarbonate that you excrete in the urine and retain what you need. Once again, here's Bowman's capsule, and there's the glomerulus ball inside there. Afferent arteriole comes in. You filter out a bunch of fluid, and then the efferent arteriole goes down by the tubules and picks up the things that you want. You reabsorb 65% of everything in this proximal tubule. Then you reabsorb water here. You reabsorb a bunch of electrolytes and things here. And then you fine-tune all the way through the collecting duct with signals from antidiuretic hormone, aldosterone, parathyroid hormone, atrial natriuretic peptide. And your kidneys have a really great ability to concentrate or not concentrate urine. If you have too much water, you got to pee it out. You'll pee out a lot of dilute urine. If you're dehydrated, you want to keep as much water as possible, so you'll pee out a small amount of concentrated urine to get rid of the things you've got to get rid of still without losing a lot of water. So you're controlling the osmolarity of all of your internal fluids at the kidneys by either peeing out more water or more stuff. You retain this approximately 300 milliosmoles per liter, by regulating the concentration and volume of the urine you pee out. And the kidneys, remember I promised you, you're sad to remember, another countercurrent mechanism. Remember in the tips of the villi, we had a blood vessel going up this way and then one coming back. And because they were so close together, the oxygen could just jump across and not make it to the tips. That countercurrent mechanism had a powerful effect because the two tubes were too close to each other. Well, we have a really strong countercurrent mechanism in the kidneys called the countercurrent multiplier, and it allows you to concentrate or dilute your urine way more than you could do just by having a straight tube that either lost water or lost electrolytes. Helps water reabsorb early and helps electrolytes reabsorb later. And you control this, so you control the amount of urine you have. You maintain an osmosis of your blood, even though your urine can be as concentrated as 1200 or as dilute as 100 milliosmoles per liter. You're still keeping your blood at 300. So here we have, think about this. Here we're coming down with our primary P. This descending loop is permeable to water, so you want to get a lot of water reabsorbed. The ascending loop is permeable to electrolytes. You want to get a lot of electrolytes absorbed. Remember, we absorb most of everything. Just the leftovers come out in your pee. So how are we going to get all this water to go out? If there's a lot if water goes out here, pretty soon the hydrostatic pressure out here is going to prevent you from getting more water out unless you have a lot of osmotic force to pull on it. Well, how are you going to get a lot of osmotic force? Well, you put a lot of electrolytes out here. The more electrolytes go out here, the more osmotic force you have pulling water. And now that the electrolytes are going out, if they got so concentrated, they would try to prevent more electrolytes from coming out. But the water dilutes them enough that more electrolytes can come out. So the water helps the electrolytes come out, and the electrolytes help the water come out. And this countercurrent mechanism, because these tubules are so close to each other, winds up causing a much greater amount of water and electrolytes that could come out otherwise. So we start off with 300 milliosmoles per liter. That's what our typical blood and primary urine is. But then so much water comes out that by the time you get down here, you're all the way up to 1200 milliosmoles per liter. And then as you go back up, you lose so much electrolytes that you get down all the way to 100. So you have super concentrated and super diluted. It helps you get more water back and more electrolytes back. And now these tubules and collecting ducts will take back as much water as you need to take back to concentrate your urine the right amount to keep everything okay. So your ADH and aldosterone and stuff will be affecting your principal cells here. You'll open and close aquaporins, and you'll take back the right amount of water now to make sure that you pee out the right amount and the right concentration of urine at the end. So if you're overhydrated and you need to get rid of that extra water, you still reabsorb a lot of water here, a lot of electrolytes here, but ADH, will be turned off because you have too much water. You don't want antidiuresis. You'll open up a bunch of or you'll close all those aquaporins, and all of that extra water in your urine will just come right on out. You'll pee a whole bunch of dilute urine. If ADH production goes up, you retain water. If ADH production goes down, you pee a whole lot. It can be as dilute as 100 milliosmoles per liter. Remember, that's as dilute as it got. So if you close all the aquaporins, you'll pee out really dilute urine, and a lot of it, called diabetes insipidus when that happens. Dehydration will cause you to produce a very small volume of very concentrated urine. So you increase ADH, you open all those aquaporins, you reabsorb all of that water, and the urine stays super concentrated. You pee out and it looks orange. A small amount of really highly concentrated urine, because you're trying to get rid of the stuff you need to, but keep as much water as you can. Diuretics affect this whole process and make you pee more. You can take diuretics, loop diuretics. You take if you have furosemide or something like that. If you are retaining water because you have heart failure and you're trying to pee more, and this works on the loop of Henle and prevents you from reabsorbing as much water in that descending loop. So you keep more water in the pee, and so you'll pee out more. Alcohol is an ADH inhibitor. It blocks the production of ADH, or the action of it, and therefore you drink alcohol and you pee a lot. A lot of dilute urine comes out if you have too many beers. Caffeine blocks the effects of aldosterone, and therefore it blocks reabsorption of sodium and therefore water. And so if you drink a lot of coffee, you pee a lot too. So alcohol blocks one of them, caffeine blocks the other one. Some other hypertension drugs work this way. Loop diuretics work in the loop of Henle, as I said. Osmotic diuretics are things like glucose when you have diabetes. If you can't reabsorb all the glucose, it stays in your urine. It draws extra water by osmosis, and you pee more. Diabetics are always peeing a lot of very dilute urine because it's pulled into the pee. So how do we evaluate kidney function? Well, you can look at the urine and see if it's got blood in it. You can look, to see if it's got proteins in it. You can look to see if it has bilirubin in it, meaning you have liver damage and you're, have jaundice. The main measure of actual kidney function, though, is glomerular filtration rate, GFR. This is the total amount of primary urine that's being made by the glomeruli before it starts getting reabsorbed. How much urine is being produced initially by the glomeruli. Remember, it's supposed to be about 125 mLs per minute in a young, healthy person. And you can do that by looking at the renal clearance of something that you completely clear. Creatinine, creatinine, creatinine. Creatinine is something your body tries to clear completely. So whatever plasma gets filtered into your from the glomeruli gets completely cleared of creatinine. So you can tell how much filtrate there was in the first place. If only part of it got filtered out, it's almost impossible to tell. But if it's something that gets completely cleared, you can use that as an estimation of glomerular filtration rate to see if you're close to your 125 that you're supposed to be. Remember renal clearance. Clearance of any substance equals UV over P, ultraviolet over parasol. Your urine concentration times the volume tells you how much of it came out in your P, divided by the concentration that was in your plasma in the first place. Let's do a couple of practice problems. Renal clearance of substance A, adenosine. You don't pee out adenosine, but substance A, okay? Well, let's see. You do a urinalysis. You measure how much, here's in the plasma. You take a blood sample and you find out the concentration of this substance in your plasma, 2 milligrams per milliliter. The concentration in your pee, you measure your pee, 60 milligrams per ml. Okay, so you must be secreting extra into the pee because this is higher than that. That's fine. Okay, so this substance, 60 milligrams per each milliliter of pee, and you're producing 1 ml per minute, let's just say, of actual pee. Not the initial filtrate, but the pee that you're peeing into a cup. Okay, this is the volume of urine. This is that you measured. Here's the concentration you measured, and here's the concentration in the blood. UV over P, 60 times 1 divided by 2. Remember, I said these numbers are easy. 60 times 1 is 60, divided by 2 is 30. So your clearance rate, you're clearing 30 mLs of blood per minute of this substance. It's simply UV divided by P will tell you the number of mLs per minute that are being cleared of that substance. Let's look at this one. This tells you two different things. How about a renal clearance of creatinine in this particular patient? Well, we took a blood sample, and they had 4 milligrams of creatinine per ml of plasma. They're peeing out, the concentration of that creatinine in their urine that you measured after they peed it in a cup was 100 milligrams per ml. And the volume that they produced was 5 mLs per minute. Maybe you had them pee after an hour and 5 times 60, whatever, so 5 times. So you had per minute, 5 times 60, so 300 mLs per minute or something like that. Anyway, whatever you did, you determine how much they're peeing per minute, producing per minute, and you find out what the concentration of that substance was, creatinine, what was in the blood, UV over P. 100 times 5 divided by 4. What's 100 times 5? 500. What's 500 times divided by 4? 125. So what's this person's GFR? 125. Is that normal? Yes, that's exactly normal. If this were a young, healthy person, their GFR is exactly right because they're clearing that amount of creatinine. It shows you that they're producing that amount of primary filtrate. UV over P. What if it's not 125? Well, it's based on age, sort of. A young person, let's say under, 35, something like that, under 30 anyway. Their GFR should be about 125. And then it gradually starts to drop as all of our body's tissues become less and less viable. Your kidneys get worse and worse over age during your life. So a 90-year-old, my mom, when she was 95, still had a GFR of about 65. Okay? But that's normal for a 95-year-old. But it's close to being kidney failure, because anything below about half of normal, that's a good, instead of actually memorizing a number, if it's less than half of normal, it's too low. If it's 70 or 80, their kidneys are still probably working okay. Although if I had a 20-year-old and it was only 70, I would wonder what's going wrong with them. 70 is pretty low. But it's actually renal disease or early stage renal failure if you get below 60, below half of what you should be. And if it ever gets below 15, you are in absolute renal failure and you need dialysis or a kidney transplant. You can't live down here. You can probably live at 50. You can probably live at 40, although it's going to become, you'll have more and more toxins building up in your blood if you're at those low levels. But if you are at 12 or something, you're dead unless you do something about it. So below half is early stage renal failure or kidney disease. And it has to be, over a certain period of time, because you could have like an infection in your kidney and make it drop down temporarily and then get better. But if it stays down there, you're in early stage renal failure or disease, and total renal failure below 15. We talked about urine before, but we'll talk about it once before. Clear. It shouldn't be cloudy. It shouldn't be pink. It shouldn't be gray. It should be clear, pale to light yellow. Deep yellow means you're somewhat dehydrated. It still doesn't mean that you're diseased, but it'll get pretty yellow if you concentrate it some. So pale to deep yellow can mean healthy, but pale to pale yellow means that you're properly hydrated, or euhydrated, EU. Remember, U means good. Euhydration is normal. Hyperhydrated means you have too much water into you. Hypohydrated or dehydrated means too little. Brown, smoky, not supposed to be. Although it can get pretty funky looking if you eat beets or something like that. And the smell, it should be nice and fresh, but if you eat things like asparagus, it'll smell pretty funky too. Remember, the pH should be slightly acidic, should be below 7.4. It can be up around 8, it can be 4.5, but these are pretty extreme. It should be sort of in the middle, somewhere around 6, 6.5, something like that. It can change with diet somewhat. A lot of proteins will make you more acidic. Very vegetarian diets might make you more basic. And your specific gravity, remember, that is the comparison of its weight to the weight of water, which is 1.000. And it should be, actually, to be normal, I would say, about 1.01 to 1.025. I'll do that. I'll do kind of a demonstration lab on that, but 1.01 to 1.025 is a more normal range. It can be this extreme without kidney disease. If you're really hydrated or really dehydrated, you can reach these without it being kidney disease. But normal ranges are like 1.01 to 1.025. That's a little bit more realistic. And other things in there, you'll have sodium, potassium, some phosphates, You'll have some ammonia in there, some sulfates and calcium, magnesium, some bicarbonate, hydrogen ions. But you won't be measuring bicarbonate or hydrogen ions. You'll just measure pH. Okay? But abnormally high concentrations of anything could mean that you either overate that stuff or that you have something wrong with your kidneys. And you're also not supposed to have plasma proteins in there, almost at all. You're not supposed to have white blood cells in there, almost at all. You're not supposed to have red blood cells in there, almost at all. You're not supposed to have glucose in there, almost at all. Most of that stuff is supposed to be back in your blood. And bile pigments may indicate that you have some liver disease. So if you have bilirubin as the primary bile pigment, if your liver isn't taking that bilirubin out of your dead red blood cells and putting it in your bile so you get rid of it, it backs up in your blood and gives you jaundice and you turn yellow, and it'll show up in your pee. And that's it. One more renal lecture to come. It will be largely on acid-base balance.